Next on primary care, what federal health care cuts could mean for Detroit and families across Michigan.
You have less people getting these services, and the people who are going to be marginalized off the services are actually the people who probably need it the most in the entire population.
Hello, and welcome to Primary Care, the show dedicated to improving the health and care of African Americans. I'm your host, Dr. Lonnie Joe. Last week on Primary Care, we began unpacking what the proposed federal budget legislation, often referred to as the Big Beautiful Bill, could mean for Michigan and for families right here in Detroit. We talked about Medicaid work requirements, potential coverage losses, SNAP changes, and the strain on hospitals and clinics and public health systems. But the reality is this conversation is bigger than one program or one policy. With nearly 500,000 Michiganders potentially affected in a city already facing persistent health disparities, these proposed cuts reach far beyond policy and directly into our homes, our clinics, our churches, and neighborhoods. Back with us to continue our conversation is Dr. Herbert Smitherman. Dr. Smitherman is the Assistant Dean of Community and Urban Health at Wayne State University School of Medicine and President and CEO of Health Centers Detroit Medical Group. Herb, welcome back. Glad you stayed.
Dr. Joe.
Absolutely. Listen, this is a subject that, could go on and on forever.
Right.
Of mega importance to everybody, top to bottom, and everybody in between. How will these cuts affect federal spending in healthcare assets, especially when we start talking about federally funded clinics?
So the good news is, although the One Big Beautiful Bill Act, which is its official name, has cut significant resources, as we talked about in the last show, about $1 trillion in safety net services, healthcare, food, housing, transportation, education, child care, you name it. They've cut these safety net services. So far, the cuts to federally qualified health centers, that is government funding of primary care clinics, has really remained stagnant. So there haven't been major cuts and there haven't been increases, although, as you know, inflation is 3% a year, and that's been going up for the last 10 years. So we have got no inflationary cost increase, but they have really held it pretty harmless at this point, because they know that as they are cutting all of these Medicaid resources to primary care physicians such as yourself, and you're having to take on more uninsured burden, et cetera, that if there's no one out there to help mitigate all of those cuts in Medicaid and all the patients who are going to lose their Medicaid, lose their SNAP benefits, lose all these resources. So they know that they need to increase in the federally qualified health center community, but what they did is held it stagnant because of just the draconian cuts in all the other safety net services.
Because cuts at this time would be devastating to operations. It is a business, and that means standards have to be met, as well as things like payroll.
Yes.
And if you can't do that, that means you have to make changes in operation.
Yeah.
Those changes in operation automatically lead to less services for a community that you particularly serve. How is Detroit doing as an entity, as a city, in terms of the numbers of FQHCs that we have? For years we were behind. Are we playing catch up in that arena?
We were very behind, I'd say about 2 decades ago, but we have caught up significantly. We're clearly not where we need to be. So we're not resourced in a way that we have enough government-sponsored primary care providers in the city of Detroit. We have a significant deficit of primary care physicians in the city of Detroit. And in fact, in the whole state of Michigan, out of the 83 counties that are in the state of Michigan, 79 of them have either a health professional shortage area or a partial health professional shortage area, which means they don't have enough doctors, don't have enough nurses, don't have enough mental health providers, don't have enough dentists. We don't have the kind of provision of health professionals that the state of Michigan needs, and we are continuing, that is continuing to decline. Now the state is trying to do good health policy like MyDocs, which I'm sure you're familiar with, where they're creating primary care residencies, but even at capacity, even if MyDocs is running full steam, you're getting 30 primary care physicians a year, and we have about a 862 primary care physician deficit in the state of Michigan, 862 docs.
So
30 a year, we're gonna be here a while.
it'll take you a generation to catch up.
Couple of generations.
Right, right. So basically, we have issues in retaining
Yes.
trainees.
Yes.
For years, we've watched people train in very fine
Train
programs
here and leave.
and leave the state and go
Yeah.
somewhere else. Are we getting the kind of support that we need to actually try to recruit and retain those people, or are we still watching them walk out the door?
Well, you have to look at the environment. You're in that environment. So in your environment that you see, your reimbursements are going down. Your compensation is going down. The burden on you is going up. Burnout is real because you're being inundated. So as we typically, if you look at the other Midwestern states, Indiana, Illinois, if you look at Minnesota, blah, 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 their reimbursements, for example, for many of their healthcare insurances, including Medicaid, are at higher rates than the state of Michigan. So our reimbursement is lower. And so it's an environment where you've got a lot of toxic mix. Revenue's going down, burden is going up, burnout is going up, and for that you're having an aging physician population. So because the young people aren't coming in, and what's left is physicians who are staying on because they care about their communities and no one's coming in.
So what can families do? I mean, we see how all of these cuts affect the business aspect of providing health care. How do we face people in the office on a day-to-day basis and continue to deal with them? How do families actually deal with things like food, utilities? What role can we play in terms of helping them in all aspects, housing? What role can we play as healthcare providers, which sometimes, if we just limit ourselves to healthcare, we are not really addressing the problem enough to affect change, even in that arena. It's going to be hard to stay healthy if you're still living in a food desert or those kind of things. How can we help patients on a day-to-day basis who are faced with these cuts? So
you and I have practiced in this community for 40 years plus. So we understand that when a patient, like you just said, when a patient comes in and they've lost their home, a patient comes in and they say, "Doc, I haven't eaten in 24 hours." Mm-hmm. Now, with respect to their hypertension, diabetes, hyperlipidemia, we're now on a more emergent situation where I'm trying to find shelter, I'm trying to find food, I'm trying to find their basic needs before I can even get to the actual medical care. And as you know, those basic needs impact someone's health status it's about 80% of their health status is based on those non-medical issues. So of course, we drop everything and we're trying to prioritize, but we don't have the resources in our practice to deal with that. So what we're trying to do as practitioners, as you know, we are trying to build better partnerships and be more effective and efficient. But even if we're maximized at that, we as primary care physicians are not interdisciplinarily resourced to care for all of the different burdens that we're being saddled with as patients come in. We want to help you basically make sure you get transportation to work, because without your job, you lose your health insurance, and without the health insurance, you have a challenge going and getting medical services.
It's all interrelated.
It's all interrelated. So the only way we're going to we are going to solve this as primary care physicians is we've got to have cross-sector collaborations. We've got to work with HUD, Housing and Urban Development. We've got to work with SNAP and food benefit agencies. We've got to work with behavioral health agencies. We've got to work with social service agencies. We have to build relationships with those. But I always say, because everyone says, hey, why don't you guys get together with the other sectors, et cetera? Well, where's the infrastructure? Where's the money
to do that?
To really do that? And secondly, why are you strapping that burden onto the primary care physician?
Exactly.
I'm there to help the whole patient, but I'm not really resourced to really do that.
One way to fail is to think you can be everything to everybody,
Yes.
especially in this business.
Yes.
You need to know when to punt, okay?
Yes.
One of the beauty behind the concept of FQHCs is that it covered a lot of the things that you were talking about, having the social worker available, having the various disciplines available, even the dental care, the prescription coverage. But that seems to only affect a small percentage of the population that we have to take care of.
Right.
I know between me and my two partners in the office, our conversation half of the time is about the social needs of the patient. I mean, you think you need another healthcare provider, but just as important as that, I need a social worker.
Yes.
Okay?
Yes.
And we don't have access.
So the question is, and we were talking off camera about developing the state of Michigan a primary care commission. So it just focuses at a state level on primary care, because everyone's talking about what this term is, interdisciplinary team. And I'm on camera, so I can't say the word I want to say regarding that, because if you want to have interdisciplinary teams, you've got to pay for it.
Right.
Okay, so if I get reimbursed for only my medical care, only treating their hypertension, diabetes, et cetera, that's the only thing, but I'm not reimbursed in that payment for any of the other services I know I need. I do need interdisciplinary team. I do need a psychiatrist, a therapist, a social worker, a pharmacist. That would be wonderful to have that. Where's the money?
Right.
I'm getting paid that I can barely pay my own salary,
Right.
let alone have that team in my office. So the reform has to be for primary care physicians. You've got to think, if you want to think of us as an outpatient interdisciplinary team, you've got to have that reimbursement such that you're reimbursing the interdisciplinary team. You're giving me resources so I can sustain these other resources to handle all of those basically social issues in my practice.
Herb, what can patients do who are hearing all of this activity? You know, you're watching the news, we're bombarded with information in this society now, and I'm not sure that I can find a patient who hasn't not heard about pending Medicaid cuts right now. What can patients do, or what should they do with the impending cuts that's coming? How do they prepare for this, if they can?
Yeah, so there are significant cuts. There are two things that are happening: cuts and administrative burden. So instead of having, for example, in Medicaid, instead of having to register and confirm eligibility once a year, you now have to do it twice a year. Same with SNAP benefits. You also, there's a lot more administrative work that you must do. More paperwork you have to fill out. Stuff is online, got to have internet. All of these things are meant to be put in place to decrease enrollment.
Automatic dropouts in the system.
Yes, so you have less people getting these services, and the people who are going to be marginalized off the services are actually the people who probably need it the most in the entire population. So what we are going to have to do, because I think government is going to, especially in our state, is going to try to help us mitigate this issue, but unfortunately we are going to have to activate the private sector. So our churches, community organizations, institutions and agencies like mental health, social services, we're going to have to step up, because we're going to have to make sure, because it's going to be a game. You know, I got to fill out all the paperwork. I got to do this twice a year, not once a year. All of these things are going to start happening now, and so we're going to have to help our community do that. We're going to have places, because that can't occur in the primary care physician office, because we don't have the resources to do it. So we're going to have to partner with our philanthropic community. So our funding agencies are going to have to start funding things that make sense for our community, not funding some survey instrument that makes no sense and won't do anything. Let's fund resources to help us address the incredible new administrative burdens that are going to be placed on people who are under-resourced to sustain these kind of benefits.
So a patient could, under the current circumstances, a patient could easily wind up at the pharmacy to get a refill on their high blood pressure medication and be told your insurance is not in effect or it's not covered for whatever reason, and they walk back out the door only to get put back in line somewhere in the system to try to qualify again for those services.
Yes, we're going to have to be much more proactive, and we are going to, and I think our philanthropic community is going to have to step up to help us fund addressing this administrative burden in locations across our community, so people have places to go to say, look, they just said I was cut off. How can you help me get back on? We've got to be able to do that in real time, man. And there's no way around it, because it's now statute.
Exactly. If not, you're going to see the same person with a whole barrage of different issues over time that present to you for care in the office simply because of the lack of ability to solve some of these other problems outside of the office. People aren't going to just leave those issues in the parking lot, okay, coming in to see you. They're going to bring them in to see you. So we've got to prepare for that to some degree. What role do you see the bigger dogs in the industry, like healthcare systems, playing in this? Too much has been given, much is required. And, we've got entities around the country saying there are no failing hospitals financially if you do the accounting from a different standpoint of view, that all the hospitals lost money closed a long time ago. Yeah, that might be up for debate, but we spend a lot of money in healthcare systems around the country. Detroit is no different than any other place with an urban environment that we go to, where the money is not being spent and the profits are not being made. We're posting profits in a lot of aspects of this industry. Do they have a responsibility to the mundane issues that patients have? Should healthcare systems be running supermarkets in an area like this, classified as food desert? That kind of thought process. What's your thinking on that?
Yeah, so 26% of the residents of this state are on Medicaid, okay? You're talking about 1 out of 4 people. They're coming into your emergency rooms with no health care. There is a huge incentive for health systems to make sure people coming into their emergency rooms who they know have been on Medicaid, were on Medicaid the last time they visited, now are off, to have infrastructure to make sure they get back on very quickly so that they can get reimbursed. So there's going to be, I think, a larger incentive to make sure people who are losing these benefits are actually in real time getting back on the benefits, or their numbers of uncompensated care are going to climb. So it's in their interest to do it. So I think the institutions will do it. They're primarily, I believe, going to do it as they always have for the people coming in their doors. Now the question is, what about the people who don't which is the larger part of the community, because people are going there for illness care. We're trying to get people basic primary care to prevent that hospital admission in the first place, to prevent the ER visit in the first place. So not only I think the hospitals are going to resource up because it's in their interest to do it. The question is the ambulatory structure, where most of the patients are. What are we going to do, and how are we going to partner in a way that infrastructures, administrative infrastructures, so we can continue to keep people on these services? Part of that's going to be government, so we need some support from government to do it. Part of is that going to be philanthropic community, people who have foundations, et cetera, are going to have to fund these kinds of things. These are perfect things to fund within communities to make sure people are getting the care, because without SNAP, without Medicaid, without housing, all you're going to see is more death, disease, and poverty. That's what's going to happen.
So what's currently available to patients in terms of food services, utility support? What kind of entities are available for people to turn to in a community like this?
Not a lot, especially you talking about utilities. You know about that, brother. They come in. No, it's not a lot for that. But people are going to be so burdened with basic needs that it's hard for a family of four, meaning an adult or a female-headed household with 3 kids or 2 kids, trying to keep a job to make sure I pay for all of this.
Daycare,
Everything, child care, whatever, as some of my benefits are being cut. Don't let me get sick. And so the question is, how do we get there? I think that's your question. How do we get there, both for the patient, the community member, et cetera? And all I can say is we are coming together to try to figure that out, but it's going to take a lot more collaboration, a lot more coordination with government, private sector, community organizations, community agencies. We are going to have cross-sector collaborations like we've never had before in this country. We need to do that anyway, but we're always doing it in an emergent standpoint. You know, you don't have to cut, you know, $1.5 trillion in safety net services and then try to say, well, you guys need to get together and kind of work it out. Well, I don't have $1.5 trillion sitting in the back of my car. Where am I going to get these resources? So I think that's a challenge.
We are into a piecemeal mentality when it comes to these sort of things, because we're forced into it to some degree, because the cuts come wholesale. And the result of that is, what can we do? So we do the best that we can, which a lot of times is really not enough. Most times is really not enough. Personally, I see it as a lack of resources, a lack of funding, and a lack of leadership. We know where the resources are headed. Everybody's looking for cuts on everything that we have from a social safety net concept. Do we have the leadership to achieve this, whether it's local, national? I mean, you're in this arena. Can we really provide, you know, people that can say, listen, this is a better path to travel as opposed to the one that we're on?
Yeah, I think we do. However, it's just like anything else. When everything around you is urgent and emergent, everybody's trying to solve this, and it's schizophrenic out there. And so it becomes much more difficult to stabilize and build infrastructure when you're always, you know, trying to stop the bleed. They're coming in, bullet wounds, You're just trying to stop the bleed and get them triaged. That's where we are. We're triaging right now. We don't have the time and the luxury to kind of build this thing. We're trying to fly the jet as we're building it, and that creates a lot of bad stuff.
That's called a crash landing.
Okay.
Good. So
that's a good term for it.
What questions should patients be asking providers in terms of their primary care physician or primary care provider? What questions should be at the forefront of that discussion at this time?
I tell people, develop your questions at home.
Before you get there.
Before you get here. Because if you're in the office and you're trying to think of things, it becomes very inefficient. So think of your questions. It doesn't mean that we have to answer all of them in that one visit, because people sometimes, when you tell them that, they come with, you know, we're on page 10, Dr. Smitherman. You know, I got this next question. And you want to make sure all their questions are answered, but you let them know that we can do it over time because it's ambulatory. So get your questions developed. If you are having emergencies, let your primary care physician know. Especially if, like yourself and many of the people who've been practicing for years and years, we know where a lot of these infrastructures are, and we can at least point in the right direction. We are trying to develop a cross-sector network of people who are doing social services, mental health, pharmacy services, you know, free clinics, FQHCs. We're trying to build that, what I call real interdisciplinary primary care infrastructure. And so we're trying to get that together right now. You know that project we're trying to work on, because I don't really see, without funding, I don't see, we're just going to have to partner and try to be more efficient. It's not going to be efficient enough to overcome 1.5 trillion with a T, but we're going to be better off than we were if we didn't do it. And the last thing I'm going to say is you need to vote.
Absolutely.
Everybody came around and said, You know, I was talking to young people, it doesn't matter, your vote doesn't count, blah, 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 blah. Well, how do you like it now?
Yeah. You know, that is a reoccurring theme in a lot of communities because whatever generation you want to assign yourself to, seems to be that people have become despondent and not realizing that that is one right you cannot let go of. You have to show up and you have to express it no matter how weak you think it is. That's something that you don't give up. We've created a Where's Waldo type of situation in healthcare. You know, the kids are always challenged from every page. Waldo is in the mix somewhere, and they're challenged to figure out where Waldo is. But you guys have been in the forefront of this simply because of the service that you render all of these years, and basically being on the front line, you know how to dodge some of the bullets at times. But I honestly think that the approach has to be collective. Mm-hmm. The approach has to be discussed. It has to be something that is not hidden. The people involved have to be held responsible. And I think that if we can continue to work on that path, we're going to have some better outcomes than we have now. Dr. Smitherman, we are out of time. This has been a pleasure. Thank you so much for joining us. We will make it happen again. Thanks, Herbert. We appreciate you. Great.
Appreciate it.
Our guest has been Dr. Herbert Smitherman, Assistant Dean of Community and Urban Health at Wayne State University School of Medicine and President and CEO of Health Centers Detroit Medical Group. The potential impact of the big, beautiful bill could extend far beyond policy, affecting care and stability for many Detroit families. Be assured that primary care providers like Dr. Smitherman and myself are actively working to help patients navigate these changes and protect their health. For Primary Care, I'm Dr. Lonnie Joe.